Good evening, everyone. We'll just give it a few minutes and let everyone join the room. Okay, get started. Welcome, everyone, and thank you for joining us this evening after a very hot and clammy day. For those I haven't had the pleasure to meet, I'm Anjana Patel, Principal Pharmacist in Pre-Assessment at the Royal National Orthopaedic Hospital. I've worked in preoperative assessment for almost 11 years, and I'm very passionate to grow the pharmacy workforce in this field. Today, I'll be joined by Sarah and Claire to officially launch the toolkit. Sarah Tinsley is the lead pharmacist at the surgery division at the University of North Midlands Hospital, and she's our education and faculty lead and a board member of the Preoperative Association. We've also got Claire Frank, who's the lead preoperative assessment pharmacist at Wrexham Mella Hospital and the CPOC Fellow for 24-25. They're also both co-authors of the UK-CPA Handbook of Perioperative Medicines, and they're also committee members of the UK-CPA Surgery and Theatres Group. Just a few housekeeping points. The webinar is being recorded and it will be available on the Preoperative Association and the UK CPA members sections of the website. And also please just use the chat or the Q&A for questions or any comments as well. So today we want to do three key things. Firstly, to formally launch the toolkit. Secondly, to share the context behind why this work is so important now. And finally, to walk you through what's in the toolkit and how you can use it in your own organizations. We'll start with the national and clinical context and hear from CPOC and UK CPA representatives before moving into the toolkit itself and practical application. And we'll also leave some time at the end for questions. So this toolkit has been developed collaboratively between the Preoperative Association, CPOC, and UK CPA. And I will invite speakers from the other organizations to give their perspectives shortly. But from the Preoperative Association view, why now? We're seeing a clear shift in surgical population. Patients are older, they have more comorbidities, and they're on increasingly complex medication regimes. This creates significant perioperative risk, and it makes medicines optimization absolutely critical. The traditional POA models led by only anesthetic or nursing teams are under increasing strain and they cannot address medicine complexity alone. Despite this need, pharmacy involvement in POA varies significantly across the UK, and we'll hear more about that from Claire today. Some services are well established, but many have limited or no input, and often due to funding or workforce constraints. The pharmacy teams are uniquely placed to address these challenges. They bring in expertise to provide medicines optimization, they reduce risk, and they support better clinical decision making, which ultimately improves the patient outcomes and efficiency. Also, the inappropriate stopping or continuation of medicines before surgery, the poor optimization, or the poor perioperative planning contribute to avoidable theatre cancellations and inefficiency and hugely affect the patient experience. So on a final note, many organizations recognize the value of pharmacy input and they've considered implementation, but they lack practical guidance on how to design, staff, or just justify services and costs. And this gap between the aspiration and delivery was the core driver to us developing the toolkit. This is not just a pharmacy issue, it is a national perioperative issue, and it's a priority. So I would now like to invite Sarah Carter. She's the CEO of the UK CPA to say a few words about why they joined us on this venture to develop the toolkit.
Welcome,
Sarah.
Thanks, Anjana. Thank you very much for inviting me. I'm really looking forward to hearing more about the toolkit. I have had a look through it. It looks amazing. And to me, I think this resource represents a number of things. Firstly, it reflects the importance of workforce planning to ensure safe patient care. Secondly, it signifies the importance of pharmacists, as you've just said, in the MDT and the value that the MDT place in the pharmacy profession, which is amazing. Thirdly, I think it represents the importance of collaboration. It's great to see those three logos together on the screen and on the resource. And this is the latest in a number of projects and guidance documents that UKCPA has been involved in together with the Preoperative Association and CPOC. So it's fantastic, and hopefully there'll be many more. And finally, I think it showcases the importance of really practical national guidance. Resources like the UKCPA Handbook of Perioperative Medicine, which Sarah and Claire lead on, and this toolkit are really key, I think, to preventing duplication of work and reducing the variance in practice and in patient care. So I think this toolkit is going to be super useful. So congratulations to everyone involved in developing it. Thank you.
Thank you, Sarah. That was very helpful. So unfortunately, I can't see Professor Denny Levette. She's going to join us and say a few words representing CPOC as well. So until she joins us, just to hand over to Claire. But so we've talked about why this is really important and it really matters. But to understand the current picture across the UK, Claire's now going to share some findings from the national survey and the work that she did during her fellowship.
Thank you, Angela. So during my time as a CPOC fellow, I really sought to better understand the extent of pharmacy staff involvement in pre-op assessment in the UK, because what we know is that there's multiple different models with multiple different levels of pharmacy staffing, and we really wanted to understand where pharmacy staff, pharmacists and technicians were working in pre-op assessment clinics and what models they were using. Next slide, please. So the survey was done in two parts. The first part was really to establish whether sites had pharmacy staff involved, and if they did, we sent them a further, more detailed survey. But we were also interested to find out what barriers they might have to having pharmacy staff in clinic. So this was a really quick Microsoft Forms, took less than 3 minutes on average for participants to fill in. And it was distributed initially via the CPOC Perioperative Leads Network, and then to try and get a bigger response rate to better reflect the UK picture, we also disseminated it through the GERF Non-Medical Leads Network, UKCPA, and the Scottish and Welsh Perioperative Medicine Society in the attempt to really reflect the whole of the UK population. Those sites that then reported that they had pharmacy staff in clinic were sent a more tailored, more comprehensive survey so that we could better understand the workforce, their service model, and the role of the pharmacy staff in that clinic. As you can see from the slide, this survey took on average 31 minutes to fill in, so we were really collecting a lot of detailed information, and we only sent that to the people that would know best, the pharmacists that were working in those clinics. Next slide, please. So when we look at the survey responses, we had 149 responses to the Part 1 survey, which was fantastic. And after we excluded any duplicates, that left 111 responses from unique sites, be those individual hospitals or responding on behalf of a trust. And it was great to see all 4 nations of the UK represented in the survey. And also we had representation from both the NHS and the private sector. Unsurprisingly, most respondents were from England, and most respondents were from district general hospitals, which reflects the fact that DGHs represent the largest number of sites and that there are more sites in England as well. But it was great to see representation throughout all the different NHS providers. Next slide. So in terms of the key findings from this, 35% of responses to this Part 1 survey had pharmacist involvement, 27% had ad hoc input with queries, and that varied really substantially from just literally someone that they could contact by phone when they needed through to somebody that was maybe available for a few hours a week. One site was setting up the service and the remainder had no pharmacy involvement. And whilst this looks like there's quite a lot of sites in the UK with pharmacist involvement, we don't really feel that 35% of the entire UK hospitals have pharmacy staff working in pre-op assessment clinic. We feel that there's probably a positive response bias as a result of how the survey was disseminated, particularly through using the clinical pharmacy networks that we had. And we feel that sites were more likely to respond if they had pharmacy staff than if they didn't, whereas both would have been just as valuable to us. On the right-hand side of the screen, you can see a breakdown of the sites that had pharmacy staff involvement. So 21% of respondents were from district general hospitals that had pharmacy staff involved, whereas there was about 50% of the respondents from regional sites, from private and hub sites had pharmacy staff involvement. So whilst we got more responses from DJHs, the actual number of pharmacy staff working in DJHs was lower. Next slide, please. So over half the sites with no or ad hoc pharmacy input had considered having pharmacy staff involved. And when we explored this a bit further, we found that in nearly 60% of cases, the reason for having no pharmacy staff or just very limited resources from ad hoc staff was due to funding, which unsurprisingly is the biggest barrier here. And whilst we can't promise a pot of money, what we hope is that the toolkit will help you reach out and demonstrate how pharmacy staff can make a valuable contribution to improve both quality and safety in pre-op assessment. And that might help with business cases. But we can also help you better understand how to use the staff you might have or the funding you might have in a better way. Next slide, please. So when we looked a bit further into the Part 2 survey, these were some of the highlights. So we got 26 responses to the Part 2 survey, which was a 67% response rate, which we were really quite happy with. Pharmacy involvement in services, as you can see from the left-hand side of the screen, was either very well established, with lots of sites having pharmacy staff in post for over 11 years, like Angela and myself, whereas other sites had been relatively newer setting up. And we feel that this really reflects a kind of post-COVID elective recovery surge where there was a renewed interest in pharmacy staff involvement. And partly why we've done this toolkit is the three of us quite often get contacted by sites that are thinking about setting up pharmacy services, and we wanted to share the experience that we'd had. So 54% of the services, as you can see from the right-hand side, had pharmacists working solely in the clinic, so no pharmacy technicians. 4% just had pharmacy technicians, and the remaining 42% had pharmacists and pharmacy technicians, which I think probably reflects the ideal skill mix in the sense that we can then have everyone working at the top of their license to practice and making best value for money. Next slide, please. So when we look at the pharmacist staffing level in these sites, we tried to work this out in terms of whole time equivalents so that it was comparable between different sites. And what we found was that the number of whole time equivalents varied significantly between sites, from as little as 0.1 whole time equivalent, which would be about 4 hours a week, right the way up to 4 whole time equivalents. And clearly, those sites that only have 0.1 of a whole-time equivalent are not going to be able to offer the same comprehensive service as those sites that have several members of staff and therefore have more resilience to cover sickness, to cover annual leave, and to cover other demands. So whilst we appreciate that everybody would want more staff, it's about trying to use the staff that you've got, and we hope that this will help with a more robust and resilient service. Next slide, please. So when we really looked into things, what's really clear, and was what we kind of felt was the case anyway, was that there's no ideal service model for pharmacy staff involvement in preoperative assessment clinic. Pre-op assessment clinics vary greatly throughout the UK, and therefore how pharmacy staff can slot into the clinic also varies. So there was a mix of service models. As you can see on the left-hand side, there was a large proportion of sites where the pharmacy staff saw the patient either virtually or face-to-face at the same day of the pre-op assessment. There were a smaller number there prepared before the date of the pre-op assessment, and then there was an equally large number that saw patients after the pre-op assessment. And really, all three of these are viable options. It's just seeing what works best for your site. If you look at the right-hand side of the screen, you can see that most sites try to reserve this service for specific patients. So not every single patient saw a member of the pharmacy team. It was just those in grey that saw everybody. So some people focus on inpatients, where you might argue that they're going to be in hospital for longer and there's more benefits. Some people saw all inpatients and specific day cases, so maybe the higher risk day case of patients, where if we don't sort out the medication issues preemptively before their admission rather, then that could lead to delays in discharge and maybe a conversion of a day case to an inpatient stay. And then probably about 50% of the sites that we surveyed use specific criteria to identify those patients. And that there is an example in the back of the toolkit of what those criteria would be, but that can be certain patient factors, complexity of medication, use of compliance aids, all sorts of things. So really it's about thinking what works in your area. Next slide, please. What you can see from this slide is really that the pharmacy staff's role is very diverse. And this slide purely focuses on the pharmacist. So unsurprisingly, perioperative medication advice and medication history taken were basically the role of the pharmacy staff in most sites. But as you can see that we've diversified in different ways. So some sites are involved in bridging patients who take warfarin. Some are involved in recommending what antibiotic a patient should have intraoperatively, or prescribing post-operative medicines using their independent prescribing qualifications. Some sites are involved in providing skin preparation in advance of surgery, so MRSA decolonisation regimes, and other sites provide bowel preparation and counsel the patient accordingly. So really, the role of the pharmacist can be varied and fit in with wherever there is greatest need in your local service. Next slide, please. And optimization is clearly a large component of what preoperative assessment now involves, with both the NHS England's guidance on early screening and also Welsh Government's 3Ps programme to prevent, promote and prepare for planned care. And with this in mind, this is an area that pharmacy staff can really diversify into. After all, we have a large knowledge of management of comorbidities, and we can put that to use in terms of optimising anemia, diabetes, hypertension, arrhythmia, frailty, and a lot of places also were involved with smoking cessation, which is one of CPOC's top 7 interventions to reduce the risk of complications from surgery. And I think really, if we can focus on those patients, as you showed on the previous slide, where they have the biggest impact, so those that meet specific criteria, it can allow time for the pharmacy staff to then also diversify into optimization. So hopefully that gives you an idea of what the current setup is in the UK, and really that there is no one single ideal model. Thank you.
Thank you very much, Claire. So I'm going to take over now and I'm going to talk you through what we've included in the toolkit. So as we've already said, the toolkit's designed to be a practical tool that you can use that can be applied across different organisations. It brings together evidence for pharmacy involvement in pre-op assessment by summarising the value of the pharmacy workforce, outlining different service models, giving information on different types of workforce roles, and providing guidance on business cases and some suggested KPIs as well. Next slide, please. So what does the toolkit contain then? So as Claire's already said, there is no correct model for pre-op assessment. It's going to vary depending on your organisation, on the demand for your service, what workforce you have in place and your local priorities. So for example, I work in a large teaching hospital that is across 2 sites, and we see 20,000 patients per year come through our surgical services, which would be different to a smaller DGH where you have smaller patient numbers and may be able to see more patients. So hopefully we've covered all of those different situations. It reflects that and supports that flexible approach for you to use. We've also looked at describing the different roles across the full workforce, and that includes pharmacy technicians. So we've gone straight all the way from a consultant pharmacist role down to a Band 5 pharmacy technician. And in that, we've outlined some roles that and responsibilities of those different bandings, and also some sentences that you could use if you were formulating a job description for any of those roles as well. And as Claire's already said, a key principle for us is enabling staff to work at the top of their license. In terms of clinical impact, we've already said pharmacy input. We know it improves medicines optimization. There's a lot of evidence out there to show that already, that we reduce prescribing errors and we can support better outcomes for patients by ensuring safer perioperative care. And there's also system benefits by us helping to reduce cancellations, utilize theatres better, and improve patient flow. Next slide, please. So in terms of business cases, we're hoping that the toolkit can give you some practical guidance to develop your business cases for your areas, including the people that you need to go and speak to get their engagement, defining the scope of your service, and obviously trying to pilot services so that you can get the buy-in that you need to progress. Measuring impact is key, and I found this from doing the work that I did with my business cases. So we've tried to include in the toolkit a number of different KPIs that you can use to demonstrate the value and support of ongoing improvement. So this can be things like on-the-day cancellations, looking at medication incidents that might come out from poor perioperative medicine care, and also some of our own experiences as well. We've included multiple examples of the real services that are happening. We have found there are a lot of really good examples of different services and different service models. So we've put those into the toolkit to kind of give you a bit more of a practical insight and some inspiration to developing your own services as well. Obviously, we know that education and training are essential to ensure sustainability of any service. As Claire said, there are some services that have got really established long-running services, and there are still some that are in infancy. And you're going to have people coming into that service who need that training and education. So we've included in the toolkits the available courses and training that are out there currently that people can utilise to ensure that they get that skill and knowledge. And Claire was obviously alluding to earlier that around different service models. And so, for example, in my hospital, I couldn't possibly pre-assess every single patient that comes through our door. It's just too many patients. So we work on a referral criteria basis, and we've included some of those example referral criteria so that you can try and focus your impact in the areas that you need to. Next slide, please. So for you guys out there with this toolkit, this is all about identifying the gaps in your service and using our toolkit to try and design your improvements, starting with the areas that you know you can have the biggest impact. So after this evening's webinar, we're hoping that we've encouraged you to go away, to look at the toolkit, to start talking to your stakeholders, the key people that you need to be involved in developing your service, and begin planning implementation. Closing message from us really is, if we get this right, we can improve safety, we can reduce cancellations, and most importantly, we can improve patient experience. Fewer patients will experience avoidable cancellations that we described, obviously, at the very beginning of this talk. Next slide, please. So that's the introduction to the toolkit. And I hope that you found that useful. And we're now going to open up for questions and discussion.
Thank you, Sarah. So if there's any challenges, experiences, questions, please feel free to post them in the chat or talk to us about it, because we're here to really share, because we've all been through that journey and we're happy to share. And following this webinar, and as you're looking at the toolkit, if you feel like you want to reach out to any of us, listen, or just get some advice or guidance on how to go about things, it would be really nice to hear from everyone on how their journey's going. It would be good to maybe present or just capture that data, and we can hopefully use that as evidence for this as well. That would be really good. Is there any questions? On there. Is there any benchmarking of funding source from the pre-op service or pharmacy service or directly from the trust? Sarah, would you like to take that one?
Apologies, just unmute myself. I think the answer is no, there isn't any benchmarking funding, unfortunately. We know this is an issue, and there are documents that outline what a pre-op assessment service should look like, but it very much generally focuses on the nursing workforce, unfortunately, because that's the way that a lot of pre-op assessments are set up. So my advice is to start having the conversations with the people who can help to fund it, and like I say, using some of the KPIs we've given, there are some that you'll be able to show. If you implement a service, you'll actually then save costings later on, which I know sometimes is difficult, but that's what you need to do. You need to engage those stakeholders. You need to be able to show what the benefits of the service are, and that will hopefully then lead to funding, because that's very much what happened with me and my service.
Thank you, Sarah. And just to add to that, we definitely recognize how restricted funding is these days, and it's not just something that you can go and gather all the data, do all the hard work and submit it in a business case, which is guaranteed to be approved. We do suggest in the toolkit ways of piloting and using existing resources, so using modules like rotational pharmacists or pharmacy technicians. I think it's difficult to kind of say, well, you must start with a pharmacist at a certain grade and then work and build a team. I think it really depends on all the services and what your requirements are. And the key thing is speaking to your leads and identifying what the gaps are, whether it's the nursing workforce or the anaesthetic teams, and work with them to hear what the actual issues and where you will add the maximum value. And then you will hopefully realize that actually, is it the technical input that you need from pharmacy technicians or the expertise input, and at what grade that comes with the pharmacist. So hopefully that can help you as well. Okay, moving on to the next question. How can I access the toolkit? So the toolkit will be available on the Preoperative Association website. It's actually uploaded on there today, and on the UK CPA website as well. So hopefully all of you can download it and access it. Next question is, it's a brilliant, useful tool. Thank you, Tara. Is there any guidance currently to the level of staff per patient population or bed space? Unfortunately, there isn't. I think, speaking from experience, I've done this for 10 years and I've had a complete service overhaul for like almost 3 times, because we're continuously adapting to what the service needs are, thinking about where we're adding the maximum value, and also thinking about how the pharmacy workforce has developed over the years. So it really isn't per patient. I think because you start small and you scale, and it's not easy to scale, it is really focusing on the high risk patients and possibly identifying what that is. For us at the RNOH, that's probably reviewing about 35% of the patients, but that's not all the patients that need to stop their medications. It's really the high risk patients. I know everyone works differently, so I don't know, Claire or Sarah, if you want to add to that.
Yeah, so just to add to that, so the Royal College of Anaesthetists GPAS Chapter 2 talks about the benefits of having pharmacy staff, including pharmacy technicians in clinic, but it doesn't go as far as make any recommendations. It's classed as an aspirational recommendation, and so unlike in like critical care where there are definite numbers of pharmacy staff recommended, there isn't anything like that. And also in the GIRF document where they did recommend the nursing ratios, again, there's not enough information out there about the pharmacy staff yet to be able to do the same, but hopefully in the future it's something that could be looked into. It would be a big piece of work, but I think at the moment it's just starting with what you've got and trying to make the use of it, as you say, to see the most, use your resource to add the most value, really.
Thank you, Claire. So the next question is from Lynn. Do you see patients face to face? Also, are you based in the POA clinic and sit alongside nurses and doctors? So I'll let Claire and Sarah share a little bit about their service so you can hear about ours, but it varies. So you'll see the best practice examples. We'll give you various modules. Again, with this module, we as a tertiary centre are doing telephone assessments, and it's following referrals from the nurses or anaesthetists. So we follow up with a telephone call. We do have clinic spaces, but we still, the nurses do telephone assessments as well, and the high anaesthetic patients are seen face to face. So we've just kind of got a model where actually we're working with the telephones, but we do have clinic space, and we're lucky to get that support and space for 5 staff in the clinic. Claire, do you want to tell us a little bit about your model?
Yeah, sure. Before I say about my local model, just to reflect that there is more guidance, more information in the toolkit about the survey results. And there was a mix of face-to-face, telephone calls, pre-planned calls, cold contact. It just, people have adapted to what works in their local service. So in Wrexham, we're a district general hospital. We've been a really well-established service. We've got pharmacists and pharmacy technicians, and we do predominantly work face-to-face, although there is some telephone contact for some patients, and also maybe telephone follow-up and to pass on medication instructions. We are fully integrated within the team, so it's a nurse-led pre-op clinic, but we're fully integrated in that team. So we ask the nurses for support with patients, and they likewise come back to us with questions that we can support them with. And we've got excellent anaesthetic support as well, which enables us to kind of progress in our careers. But yes, we're sort of face-to-face, fully integrated as part of the clinic in general.
Thank you, Claire. Sarah, would you like to tell us about yours?
Yeah, so as I said, we work in a very large teaching hospital. We're covering 2 sites, so we do cover quite a large geographical area. And we are mainly telephone-based assessments. I have got another 8A pharmacist now that we do try and get clinic space, but that is a lot of the problem for us, is getting clinic space, particularly when the anaesthetists are also covering clinics. So we do most of our stuff by telephone consultation, and it's usually in relation to the nurses sending us a referral, although we do also review our upcoming inpatient admissions, usually about a week before, to try and identify any patients that may have been missed that we think are complex and we want to contact them. But yeah, ours is mainly telephone-based assessments.
Thank you. I think it's very helpful to hear from other trusts and obviously get ideas, adapt, and bring something back to your services. So as a follow-up and a vision to this toolkit, we are going to hopefully hold a series of webinars or meetings for networking and sharing, having people present their best practice or even just their journeys. So hopefully, if that's something you're interested in, please leave your details in the feedback that you'll get after the webinar, and we can be in touch with you if you're interested in attending as well. The next question is, are any of the courses in the toolkit applicable to both pharmacists and pharmacy technicians? Yes and no. So we actually have a dedicated course for pharmacists, which we launched this year. And again, the vision is that we will be developing a course dedicated for pharmacy technicians. It probably isn't suitable at the moment because we are trying to cover a range of band 6 or band 7 rotational pharmacists up to 8A, B, C. So we are trying to tailor it. It was our first one and have learnt lots from it. And hopefully we will be able to develop something for the pharmacy technicians as well. Next question is, what's the referral criteria that you use? Claire, do you want to take this question?
Yeah, so in my hospital at the moment, we don't use referral criteria. It's something we're looking to introduce. But what we do have is a triage tool that the technicians use when they do the medication assessment to see whether they can give the advice themselves or whether they should refer the patient onto a pharmacist. So typically our pharmacy technicians manage about 80% of the workload, or are able to advise on 80% of the workload. We reserve the pharmacist level advice for things like anticoagulants, antiplatelets if they meet specific criteria, biologic disease modifying drugs for arthritis or for psoriasis, and insulin. But really, most of the patients can be managed by a pharmacy technician. So that helps us to kind of direct it so that we're working to the top of our skill set, really. But yeah, we hope to introduce referral criteria. I think the difficulty we have is our service has been established for so long that it's trying to pull back in some areas so that we can spread out more into the optimization, which I touched on earlier.
Fair. So we have a referral criteria, which we again continuously adapt. We have a future NHS workspace that we have with pharmacists and pharmacy technicians. So anyone interested in joining that, please reach out to us, or you can send in a request to join the workspace. We have examples of referral criteria in there, and the toolkit has a very extensive list of examples that you could use. We don't by any means say that is every patient on that list needs to be reviewed, but it's a combination of what other trusts and everyone does around the country, with just some examples of where you would provide maximum benefit with reviewing some of those patients. Sarah, would you like to add anything else about your referral criteria?
Just to reiterate that we've obviously included it in the toolkit, and it really will depend on what you can facilitate. And so I think there's a whole host of medicines and conditions that you could probably look at, but you've obviously got to be able to support that referral when they come in. So it will very much depend on your service areas. So you just need to look at the examples we've given you and try and pick what you think you could manage to cope with in your service.
Thank you. Next question, is there any evidence of financial saving once the pharmacy team is in place? For example, reduction in post-op bed days. In a world of financial constraints, would be good to have some evidence of savings to increase chances of funding. Sarah, I think you're best placed to answer that one.
So as I said, in the toolkit, we have given some KPIs that you can use to try and look at how you can develop your service. So from my own personal experience, one of the exercises that I did was look at on-the-day cancellations. It was a little bit laborious, but what I did is I got a 12-month snapshot of on-the-day cancellations, and I went through them all and picked out all the ones that were due to medicine-related issues. So things like patients forgetting to stop their anticoagulants or not following the advice correctly. And when I went through that, I found that about 15% of those cancellations were due to those medication issues. And then we had some funding to do a pilot. So we did a 6-month pilot. And we then went back and looked back at those cancellations, and we found that there were only 5% of the cancellations then occurred due to medication-related issues. It wasn't very clean, I would say. It was quite a bit sort of rough and dirty how we did it, but that's how I did it. And then what I did for those cancellations is work out a costing. So obviously it depends on how your organisation works. We are currently on a block contract, so it's a little bit more difficult to demonstrate a saving. But if you're getting paid for that activity and you lose it, you can then put a cost to the activity that you've lost on that day. And when I did it, it came up to about £66,000, which more than pays for a pharmacist in your clinic. And there are also some other good examples. So I know in Manchester, they did a paper, and it has been published, where they actually showed a reduction in length of stay. They specifically looked at colorectal patients and upper GI and vascular patients, and they reduced length of stay by 1 or 2 days for some of those patients. Again, that's something else that you can look at. So they're probably the two things that a trust is probably going to sit up and take notice of, as well as all the obviously important things about patients and things like that. They're probably the two that you could show some real financial savings.
Yeah. And just to add, it's a project that you embark on, again, with the optimization at the moment, liaising with primary care, but actually pharmacists in the pre-op clinic are in a unique position to do that. A lot of them are independent prescribing pharmacists. So it's about collecting that evidence, because the optimization is showing to reduce the length of stay. So I think, again, taking that angle is probably a different way of looking at it, rather than just focusing on the medicines to stop or continue and the consequent cancelling of theatres. I think also just to add to that, there's a different angle that you can take to this in terms of looking at income generating clinics. So we look at that at our trust, and we have outpatient appointment clinics booked for our patients. So that's probably something you could explore, where you actually show the value and there is some income from the pre-op clinics as well. Next question, is there any work to look at pharmacist involvement in the patient pathway and GIRFT guidelines in the same way that pharmacists are key workforce in ITUs or acute medicine? Claire, would you like to take that one?
Yeah, I briefly touched on this earlier. I'm not aware of any current work in regard to this, but I think it's definitely something that in the future, as pharmacy staff become more embedded in pre-op clinics, it's something that could be looked at, but I obviously don't want to speak on behalf of GIRFT.
It's a bit difficult. I mean, we are keen to explore different ways. Again, the Preoperative Association would definitely support that. In terms of defining it for every kind of service model is very difficult, but we are trying, again, hopefully this is the start of, trying to embed the pharmacy workforce in pre-op and go on that journey to define that as well. Next question from Surinder is there published data on reduction in surgery cancellations with pharmacy teams running POA clinics? I'll answer this and I'll let Claire and Sarah come in. To my knowledge, I don't think there is any published data. I think a lot of trusts are probably collecting that data as part of audits or part of their business case development. But at the moment, there is no published data. So if you are looking to use this toolkit and embark on that, it's a wonderful opportunity to maybe collect that information and get it published and share your findings widely as well. Sarah, Claire, would you like to add anything to that?
Just to add to that, I did a similar piece of work to what Sarah did, looking at the cancellations on the day related to medication. And in the space of a year in a district general hospital, I think we had 3 cancellations that could potentially have been due to the patient's medication. So as sort of the flip side, because we had the service embedded, it was a low number rather than the high number Sarah found. But it was another way of kind of proving, and it's an ongoing KPI that we've got just to try and see. But that wasn't published as such, just an abstract at the Pre-op Association conference a couple of years ago.
Thank you, Sarah. Next question from Amanda is, how is the support system in place, as during these pre-op clinics, patients quite often ask questions around the procedure itself, especially at telephone clinics? I think if I just answer that from my experience, I think you just pick that up with experience and you gain that knowledge. And if you're not able to answer it as a pharmacy team, then you would just tell the patient that you would signpost them to the right place or person and give them the contact. And they often really find that helpful as well. Sarah, Claire, do you have anything else in your experience to add to that?
I was just going to say the same thing. So it's quite funny. I've actually been doing some training with my band 6-7 pharmacists, and I said, we are often, for us, because we do the telephone clinic, the last port of call for that patient before they have their surgery. And that's the point at which suddenly they're going, oh, I haven't asked this question or that question. And they do ask. I have found in my experience, they don't expect you to know the answer when you explain to them that you are part of the pharmacy team. But they should, hopefully, if they've all had a pre-assessment, they should already have the ability to contact that pre-assessment team back. So I usually just signpost them. Or if it's things like how long will I be in hospital, I usually say have that conversation with the surgeon on the day and things like that. So it's just about knowing who you're going to refer to if you don't have that information. But like Angela says, the more experience you get, the more able you are to answer those questions.
Thank you. Are there any other questions? I think that's the end of my list. If anyone has any other questions or any challenges they would like to share as well, we have to hear from anyone. One more question. Roughly how much time is allocated for each patient consultation? So this is a bit of a tricky one, isn't it? Because every patient's different and you'll end up with a patient with just 2 medications or maybe 20 in the realistic world. It's about, again, training your workforce into making sure that consultation's kept precise and concise to time, and then have time for the follow-up. So for us, we have the admin time to book our appointments, do patient letters, document in the notes, so we account for that. So we limit our clinic reviews to up to 30 minutes. per patient, and we do pre-admission calls, so we do a reminder call for them 7 to 10 days before their surgery, and we allocate about 15 minutes for that. We kind of predict our demand and capacity based on those numbers. Sarah, Claire, would you like to share about how long roughly you take in your consultations?
I think it's really tricky to say, isn't it? It really depends on the complexity of the patient. And it also depends on whether you're doing the medication history or if that's been done by a nurse and you're just doing a referral to deal with, providing specific advice on the apixaban, for example. But if you've got a patient with polypharmacy and you're going through the medication, particularly if they're not concordant with the prescribed regime, then it can take some time. But what we find is if it takes the pharmacy staff time, that would equally have taken the nursing staff a long time to do that. And the patients that are generally complex for the pharmacy team is because of polypharmacy, which is because of multiple long-term conditions, and therefore they're the ones that are most complex for the nursing staff as well.
Thank you. Next question from Ruby is the toolkit only accessible to POA and UK CPA members? So no, only the recordings will be available in the members sections of the UK CPA and the Preoperative Association websites. The toolkit is available and free to all, so you can download it from the Preoperative Association website today, and it will be available on the CPOC and the UK CPA websites as well. If you are having any difficulty accessing it through websites, feel free to reach out to any of us and we can email it to you as well. Next question from Charlotte is, what system do you use to find TCIs when patients are only listed once they have completed pre-assessment, especially for biologics, etc., which need to be stopped weeks in advance? I'll take that and then I'll let Claire and Sarah share their systems. So we currently use Epic. So we have quite savvy reports that are generated for us, but very dependent on that medication being added to a patient's medication list. And we have built-in reports that flag those patients to us, whether they have a TCI date or not. And that's what we tend to use for making our pre-admission calls 7 to 10 days before their surgery. We're also proactive in doing pre-op appointments. So if we know that a pre-op appointment is booked quite close to the surgery date, we do our pharmacy reviews before that, just to anticipate any cancellations or give us extra time for their pre-op planning as well. Before we went live with Epic, we had a system where we would use risk flags or things like that. I think it's a bit difficult when you're paper-based, and it's a bit difficult to track those patients as well. And I might let Claire and Sarah say a few things about their systems because they've just moved to electronic systems as well.
So I would love it if patients didn't have a TCI before they had their pre-assessment. Most of my patients already have their TCI, which can be very difficult. So we very much rely on, if they haven't had a TCI and they've got a pre-assessment, we rely on the nursing staff identifying those patients. The nursing staff in our pre-assessment actually say whether that patient can be listed. So they'll actually put a note on saying what their status is. So if they're on a drug and we need to do something with it, they hold them so they can't be listed by the scheduler. And then they would do a referral to us. So that we do rely on that. We are currently looking at a new system where we will screen patients coming in from so as soon as the GP refers them in, we'd screen them at that point. Again, it's something that's quite new at the moment, so it's quite difficult to filter out. We're getting quite a lot of patients that are coming through that system. So how do we then target the ones we really need to look at targeting can be quite difficult. But yeah, so that's how we very much rely on the nursing staff highlighting those patients to us at the moment.
And just to add to that, at our NOH, our nursing team are very supportive with making sure those patients are flagged. So there's an opportunity at triage to flag those patients in a certain way as well. The Wolfram patients are flagged to us straight away. So when we know that they are coming for their weekend appointments or anything, then we can be proactive with their bridging as well. So maybe that's probably an opportunity you can use for maybe risk flagging them or highlighting them early as well.
Just to add to that, just to add to that, we're still paper-based in terms of our assessment. We've got electronic prescribing, but we've not got the fancy Epic system that we would love. So currently, we just rely, again, most of our patients have a TCI date when they come to clinic. But for those where they're on a medication that's going to be an impact, or for something where we anticipate that, like biologics, we're going to need to plan carefully. We liaise closely with the patient booking team to make sure that the patients are booked at an appropriate time. We've reached out to them. We regularly get emails from them, phone calls, and we leave messages on our patient administration system for them as well to identify those patients. So if they're moving, say, a patient on warfarin forward because they've got a gap, they know not to if they're trying to bring it in for the next couple of days, for example. But yeah, it's just kind of working within the wider team, not just the pre-op team.
Yeah. And I think we've done a lot of education for our schedulers as well. So they look out for our patient letters, which are shared and available for them to view. So they know which ones need a 4 weeks notice or 5 days, or it would just flag to us saying, well, that's a warfarin patient or a haemophilia patient, just letting you know we've used them. So I think that's another key area that we could focus on as well. Next question from Maya is, with telephone clinics, answering referrals or advising patients, what tools do you have to support you with contacting patients if they don't have set appointments? Sometimes difficult to get hold of or don't answer numbers they don't know, etc. We do have this challenge a lot where we don't have pre-booked appointments and patients will tell us that, I would have liked it. And that's one of the biggest things that we get from our patient feedback that we collect. Unfortunately, with the staffing model that we have, although we are 5 full-time pharmacy staff in the clinic, some of our rotational pharmacists do get pulled away, and planning those clinics is very difficult. It could work in some modules, but I think there's things that you just have to err on the side of caution, where you have to allow for the urgent patients to be reviewed or TCIs, and a lot of planning with rotas and fixed appointments. Again, the thing we talked about, you have to have limited time for your patients. So where actually you do get caught up with the 40-minute call, that impacts every appointment. So it is a bit difficult to work with that model. And for us, in terms of just trying to get hold of them, we just persevere and keep trying to contact them. And eventually we do. If it's arranging a appointment that's convenient for the patients, then we arrange that. Sarah, do you have any tips to share with that?
I would say the same thing, that we do struggle with this sometimes. So when we first started doing our service, it was during COVID and everybody was at home. And then once COVID went and everyone started going back to work, that became really difficult for us. But I often say to patients, is this a good time now? That's the first thing I often say to them, to obviously try and get over that. And we do often find patients are out and about. A lot of patients are really happy though to be contacted later on. They'll say, oh, give me a ring at this time or whatever time or another day. So it's just about perseverance a lot of the time with them, and just obviously, I think it's explaining that you're calling them and that you might, are they free? And if not, you can call them back at another time. We do sometimes have the odd patient who doesn't like to be contacted by telephone, and I just say that's, they're the oddities, and we just have to manage them when we get them. So yeah, it's just something you kind of just have to work through, I think.
Thank you, Sarah. Next question from Ruby. Do you have any pharmacists using preoperative medicine as an independent prescribing area for their prescribing qualification? So I'll speak for myself, and then I'll let Sarah and Claire tell you a little bit about their scope. So I am a prescriber. I've been prescribing for 10 years. We do optimization, so it's quite generic, or if we actually feel that the follow-up, because we're a tertiary center, needs to be with the GP, then we will refer them, but make recommendations. In terms of what's on our scopes, it's the usual, the bridging, anticoagulation. We do anemia optimization, and we have specific scopes that specify that we are allowed to prescribe according to hemophilia plans or hematologist or cardiologist recommendations specifically, where you're not doing the diagnosis, but you're aiding that prescribing and making it safer. So we have the scopes termed like that, and I'm happy to share that with anyone if they would like to have a look at that. Would you like to add to that? Is there anything different on yours?
Yeah, it's very similar. I'm also an independent prescriber. Don't utilize it as much currently in my role. But yeah, my scope of practice is iron deficiency anemia, hypertension, reflux, also bridging for patients receive on warfarin that require low molecular weight heparin bridging, which again I think is something that came through in the survey results. But there's lots of scope out there for pharmacist prescribers in the future.
So I'm just going to pick up just because Ruby's also put a caveat on that. So she was saying she was meaning for junior pharmacists or trainee pharmacists pursuing their independent prescribing qualification. So I think you'll see from what we've been talking about this evening that there are not a lot of pharmacists in pre-op assessment, and those that are probably already established pharmacists, and if not already got their independent prescribing, are very close to having it. So I think our experience is very much we have got a lot of experience. So I did my prescribing qualification in 2009, which is a really long time ago now. So I think that's probably something that if you have somebody who's interested in doing it in that area, you would have to develop that with them in terms of the scope of practice. But we have, like Claire said, we've got a lot of examples. So I did mine initially in pre-op assessment. So it was all about anemia, giving PPIs, all that kind of stuff. So again, if you need a little bit more information about that, we could probably support.
And just to add to that, so myself and my Band 8A pharmacists are DPPs, so we have tried to explore whether we can do training in pre-op. It is a bit difficult with anticoagulation because you don't get the differential diagnosis and you're prescribing protocol based a lot more, whereas you don't get to do that kind of diagnosis and assessment as much. So it's a bit tricky to train them in anticoagulation. We have tried it with anemia as well, but it's very, very limited. And actually, there's only so many anemic patients you could see and provide them training over that course. So it's not an area that has worked for us at the moment, but watch this space. I think for hypertension or other clinics, it possibly could work. And we do also have the foundation pharmacists who come in and spend some time in pre-op and gain that experience because they're gaining extensive experience in it as well. Amanda is asking if we will be looking for a wide collaboration of studies together so we can generate stronger evidence. Absolutely. I think that we're all still working in silo, even though we have been working in pre-op for 10 years, and there's a lot of scope there to just start gathering this evidence, doing it collectively and not repeating everything. So just there is definitely some scope there to work together. So please reach out to us if there's anything that we can support you with or help you and guide you as well. Amanda Junior and intending to do, so Amanda's asking, hi Ruby, this is Amanda Junior and intending to do VT peri-op management, and that's probably a good one because you can look at post-op kind of plans as well. Thank you very much. I think I'll bring the questions to a close there. It's been a very engaging webinar, and it's really nice to hear and see what everyone's doing and what kind of questions are popping up from here. Like I said, we are happy to be contacted if you need any support, if you need any help with anything. Do take some time to look at the toolkit and give us some feedback on it. For the pharmacists on the call that are not aware, we do have a network of pharmacists. So I mentioned the Future NHS Workspace, where we share documents from different trusts that can guide you. So don't start everything from scratch. Do reach out to everyone that's out there because you don't need to repeat a lot of that work. And you can focus on things that will add value. For example, collecting data for publication. And we also have an informal WhatsApp group of 120 pharmacists across the country, either looking to develop pre-op clinics or currently working in pre-op. We reach out to each other and advice on medicines or anything. So if you are interested, please reach out to me and we can add you to the WhatsApp group as well. Sarah, would you like to say anything before we close?
I just want to say, I really hope this has given you some inspiration to go away and start developing your services in your areas. We need more pharmacists and pharmacy technicians involved in this area. We have got a lot of work to do to catch up from what COVID did to our elective surgical waiting list, and we can be a really big part of trying to make sure that we claw all that back and help patients get better outcomes from their surgery. So hope it's given you some inspiration.
Yeah. And I would just add, start small, start with what you've got, try and involve pharmacy technicians if you can so that you're all working at the top of your license, and try to be as integrated into the pre-op team as possible rather than working in silos. But anything you can do is a step in the right direction.
Thank you. Thank you everyone for attending. Like I said, hopefully you can go and get some fresh air and cool down, and the recordings will be available on our website. Thank you.